stuff, our webinar on length of stay. And sorry, could we just go back to the previous slide? There we go. Yeah, sorry. I think there might be a delay. Thank you. So we've got a length of stay webinar today, and Maidstone and Tunbridge Wells are going to be presenting to us. I've had a look at the slides and they look excellent. We've got some really great practice to share and hopefully to get some of those cogs whirring. So my name is Rebecca Dunkley. I'm here to cover for Emma, who's on a very well-deserved holiday and has asked me to chair this session. My background is operational management in community services, and we do a lot of non-elective stuff. And I'm really excited that this series has kicked off because I know the success of the sharing elected stuff has had, and I'm, equally excited to see what we can share in this field. So we're going on to introduce other people here that we've got as part of the team. So I'm going to pass over to Lindsay for a quick intro.
Thank you, Rebecca, and apologies for my voice. I've lost it somewhere over the last few days. So my name's Lindsay Ogilvie. I'm a project manager with NHS Horizons and work with various other colleagues on the Proud2bOps programme. So it's lovely to be here with you all today.
Thank you, Lindsay. I just also wanted to point out that we've got, I guess, part of the sessions that we've got. So on our fourth slide, I think there might be someone with your mic on. I can get a lot of background noise. So if you just check you're muted, thank you. That's really helpful. So I just wanted just to share with you what we have already showcased as part of sharing non-elective stuff and what we've got coming ahead. So you've got dates for your diaries here. We did virtual wards on the 23rd of January. So that was Leeds Teaching Hospital. And if you want to get some of the slides or get information, I'm sure if you just put it in the chat that we can make sure you've got the content. We've got length of stay today. Inpatient flows on the 29th of February, and that's being presented by our colleagues at East Lancashire Hospitals. And that we're going to listen and understand about how improvements have been made to flow. And then our next item on the calendar is on the 5th of March, and that's single point of access, and that's by Sandwell and West Birmingham Hospitals. And there we'll explore opportunities around the single point of access. So I'd like to thank TeleTracking, who are also part of today's session and are with us here on the call. So just wanted to go through our values and behaviours. Proud2bOps is a network that is all around having safety, psychological safety in particular, so trust, respect, compassion. We've got mentorship across the network, and we value inclusion and diversity. We've got our value around development and being open and curious to learn, to generate ideas, so sharing this type of session, and leadership and improvement. And finally, recognition, where we focus on positivity, passion, we celebrate the good stuff, we have energy, we reward, and above all else, I know Emma wants us all to have fun. So I guess if we just maintain those ethos and remember that that's why we're here. So on to the next slide, just a bit of a background. So some of you may be new to Proud2bOps or just maybe wondering where we're up to. 15 members started around October 2017, primarily focused in the Midlands, where Emma founded the network. And I guess if you can just see that sort of spread and the scale, we've got over 1,500 members as at December 23, and really rich and diverse network now nationally. The colour codes there are around the local regional networks that we've got, and now there is one in every single part of the country. So on to the next slide. So we've got a QR code for you to scan. So I'll leave that on the screen just a little bit, just so you can get your phones out if you need to. And this is a good example, I guess, of ops innovation in the non-elective space. So if you want to share anything with us, then please scan the QR code and get in touch, because we really want to hear about what's going on out there. I'm based in community and I'm really keen to hear about what's going on outside of the acutes, because I know there's lots of really rich stuff going on out there, and it would be great to hear from you all. Okay, I think we've had that there long enough, so we'll move on to the next slide. So we've gone through some of the sharing non-elective stuff series that I've listed just a few slides ago, but we've also got the following items. We've got training sessions, and then sessions that are targeted around other areas, so emotional well-being and well-being and emotional fitness. We've got an engagement session in February as well. There's some learning and development sessions around data, information and financial management. So this has come around, there's been discussions around the literacy of operational managers and being able to support the newer operational managers who maybe have had a bit less input, particularly around COVID. And that came out at our a big exec event that we had at the end of last year, and certainly Amanda Pritchard has mentioned that her wish is to sort of really focus on that kind of bread and butter skill set for operational leaders. And then into May, we've got an in-person event, so please put that date in your diary and put a hold in there. So when we hear about the venue, I'm not yet sure where it's going to be, but we do try and spread them around the country so that we get equal access. And then in November 24, a bit further ahead, we've got our annual Congress and Awards, which I believe is our first one. So we're really excited to see that in the diary and hope you can join us for that as well. Okay, so I've done enough talking. Please use the chat as you have been doing to. Sorry, I think someone's accidentally muted me because possibly somewhere else. But I was just going to say, please use the chat for live Q&A. Save your questions for hands up at the end if you prefer a hands up approach. And I will hand over to Sally and Carl to introduce yourselves and take over. Thank you.
I'll start, Carl, shall I?
Yeah.
So I've also got a technical gremlin, so I can't see what you can see. So I am moving the slides along myself. So apologies if it comes across as being a little bit out of sync. So I'm going to move on to the next slide because we can cover that off the next slide if that's okay with everybody. Okay, so first of all, thank you very much for taking the time to join this. If you're anything like us, it's a busy time of year, challenging time of year. So I think that TeleTracking and MTW would like to thank you for taking the time to come and listen to some of the innovation that's happening, particularly with the partnership between TeleTracking and Maidstone. I'm Sally Foy. I am a nurse by background, as you can see. But for the purposes of this presentation, I'm going to call myself an urgent care director, which is my job title. But first and foremost, I am a nurse. Carl will be able to introduce himself. My background is obviously in nursing and operational flow for many, many years. Too many years to talk about, really.
Great.
Carl.
Thanks, Sally. Yeah, just to say I'm Carl Davies. I'm the Solutions and Strategy Director for TeleTracking Technologies. I am actually a clinician by background, as are many of our team. And I worked then for about 10 years in operational and strategic roles through acutes, ICBs, ICSs, before joining TeleTracking a couple of years ago to help with this kind of mission of supporting acutes and the community with patient flow improvement and reductions in length of stay.
Okay, I'm moving on the slide now. I feel like I'm in control. Okay, so I'm going to give you a really quick overview of Maidstone and Tunbridge Wells, so you know what we're talking about. So as you can see on the slide, we are a large acute trust down in Kent. We've got two main acute sites, Maidstone Hospital and Tunbridge Wells Hospital. Interestingly, both with fully functioning ITU and both with fully functioning ED departments, which is quite unusual. They're about 20 minutes apart, 25 minutes apart, and we are very used to transferring patients from hospital to hospital to support our operational flow. We see probably about 750 patients a day across both of our sites. And we are also home to the the large Kent Oncology Centre, where we service about 1.9 million patients. We've got 700,000 staff, and yeah, that's probably it. Yeah, Carl, want to?
Yeah, so TeleTracking essentially are a company that's 30 years old and has a strong history in terms of working and supporting acute hospitals mainly, and then broadening out more recently into more kind of system-based solutions. We have a large footprint in the US, but also through Europe, and around 30 contracts in the UK, with around 5 of our command centres, coordination centres in the UK. So we work with key partners across the UK on that. We range from a large number of single point products that we then combine into a series of solutions that tackle some of the key issues around patient flow fundamentally. And so what you'll hear about today is how we've kind of combined a number of those single point solutions to support a care coordination centre, how that's kind of benefited the staff and the patients in terms of the ways that they may work, the importance of the partnership between TeleTracking and MTW, and how that's kind of evolved and where that will go in the future, and then how we're looking to broaden that out to support the more system-based working and the recent developments around that, and our role in doing that. So yeah, look forward to the rest of the presentation. Okay, so just as an example of where we go and how we support, when we started with MTW, you may all recognise the kind of historical way of managing the communication of information across the system as to current state, situational awareness, was based in sort of pen and paper and people physically chasing information around the system. And what that does is obviously introduce consistent pressure within the system and has a negative impact in terms of the way we kind of continue through activities. So we had a loss of bedtime. So when we talk about bedtime, we're talking about the time between one patient leaving a bed and the next patient entering. We call that a lost bedtime. And then impact on length of stay. Patients were staying longer than they needed to for activities that we could expedite through improvements in a range of workflows. That obviously added increased administrative burden. There was decreased use of optimization of operational staff. And so it resulted in a lot of pressures across the system that needn't be there, that were adding into the daily workflows of the staff and the clinicians in the system. And that then obviously had a significant impact on a range of key indicators around performance, RTT, impact on the care quality, and patient experience. So what we did is the first phase of work was to look really at how do we make some rapid improvements that benefit both staff and patients in terms of where the greatest pressures lie within the system. So we can go on to the next slide. This, I think, is perhaps the easiest way for people to visualize how we have the impact. And I think what we wanted to do today is talk about how technology can be an enabler for improvement and organizational development and change, and actually releasing value from the system. So there are two main areas that we try and focus. There's the time that the patient spends in the bed, so their length of stay, and I'm not talking physically in the bed, just about the length of stay, and the time out of the bed between those patients. And we refer to that as length of stay, as everyone does, and the idle bedtime or the lost bedtime between there. And what we do is we have a range of single point solutions then that can provide support for a range of different workflows across the system. So whether that's the time that the patient spends in the ED, how long it takes us to allocate beds, portering or movement of patients or equipment to support patient flow, board and ward management time and the way we function on the ward to help patients move along their journey whilst on the ward, and then around the discharge processes themselves, and how do we then automate and improve those processes and support bed cleaning along the way. And so what we do is we start with the workflows first and foremost. It's around thinking about where does the current way of working add pressure into the system, what do those workflows look like, and how can we improve them? Where we can improve them and automate them, we will do so. Where we can make them more streamlined, we will do so. But it's all built around trying to release the pressure from the staff. Now, what's really, really important on this is that that time that we release from the system can be used in a number of different ways. We know that. And that's really about a leadership decision around how that improvement in effectiveness, we'll call it, can be used. And huge credit to MTW, because what they continue to do in partnership with us was look at how they use that time to benefit more broadly the organisation. And so they looked at the quality improvements, the performance improvements, and really the cost improvements came second. And we know that they will shortly follow if we need to, but it was really much driven by quality and performance improvement. And so they've managed to reallocate that time that's been improved to key activities around performance and quality improvement. And then we have committed to a long-term partnership, both parties, to continue cycles of change for the foreseeable future until we continue to release benefit and improve. So there's some big visions for the future, which we'll allude to later. But I'll let Sally just talk about the kind of impact that it's had on the shop floor first and foremost. Next slide.
Always someone on mute. It's never normally me. Okay, so I think that anyone in ops will recognise what I'm going to talk about now. So prior to TeleTracking and that partnership, we had escalation wards that we opened in probably November and didn't close until June. They weren't funded. There was obviously a financial issue around that, but also a quality issue. They were poorly staffed with not substantive staff, and that caused us a problem for many, many years. I think one of the things that we're proud of is that for the last 3 years, this year, well, we're not in March yet, but we have closed already some of our escalation beds. We have managed to hold on and not open any of our escalation beds until probably, I think, about the 7th of January, and we are, which was 45 beds we had been able to kind of accrue over the year by not escalating into them because of our improved performance. And we're on track to close all of those beds by the end of March. You know, we're in February and we've already closed 2/3 of one of our escalation wards that we were unable to do previously. Everybody has seen a growth in ED. So like most of you, we've seen a 20% increase in ED growth. And the saving of 15 beds per day has actually allowed us to manage that increase in ED without having any significant effects on flow and outcomes for patients. The other thing that you will recognise, all of you in ops, is that historically, every winter, a surgical ward, or certainly for MTW, a surgical ward was almost turned over into a medical ward. So it was difficult for electives to continue in the same way that they do throughout the rest of the year. For MTW in particular, we had a large turnover of nurses. Nurses just did not go into work in surgery to look after medical patients. And as I said, we had a large turnover of surgical nurses, and we're very pleased to say that we have now recruited and we're retaining them because we don't have medical outliers in surgical beds. I think the most we've had thus far this winter is about 9 medical patients sitting in surgical beds. In fact, quite often it's the other way around. Surgical patients are sitting in medical beds. I won't bore you with all the details. So the effective way of working. So we have, with the introduction of TeleTracking, introduced a care coordination centre. If any of you get the opportunity to come to Maidstone and look at it, please do. It's a co-located area where everybody that has a part to play in flow is co-located. So if we needed a bed cleaned very quickly on Ward 12, the facilities team are there and can facilitate that much quickly. Our integrated discharge team sitting there. We've got a tactical commander in there that oversees flow for the day. So it's just really improved the effectiveness of the way we work here at MTW. We have much more lifetime information and visibility of information to share at bed meetings. We have got a very clear SOP for our bed meetings, and TeleTracking interlinks with that really successfully. What we haven't had previously, I think, is a clear visibility of all of our discharge pathways. So pathway 0, 1, 2, 3. It almost used to be like a bit of a guesswork. We think we've got 10 patients on pathway 3. We may have had 20. We would never know. But with the tracking system, we can now very easily identify at a push of a button how many patients on each of those pathways we've got and where they're situated. And what that has meant for us in terms of improving flow is that we can now have daily PTLs. So we have pathway 0 PTLs every day, and pathway 3 PTLs every other day. Pathway 2 we're working on, but we never had that the one version of the truth prior to having TeleTracking. I think I'm a nurse, so probably one of the most important things for me to talk about, and we don't talk about it enough when we're talking about electronic bed management systems. We talk about efficiencies, and of course we know with efficiencies comes quality improvements, but I wanted to be just to highlight some of the things that it has given us in terms of quality. Much like the pathways, we never had a clue how many patients we had that were being held under a mental health section or being held under a deprivation of liberty section. You know, we just never knew that. Again, it would be like, I think we've got 10, I think Ward 12 have got 2, but we never knew. But what we get now is in my inbox every morning and live time, a kind of report that tells me exactly where those patients are, which kind of helps us when we're allocating patients from ED to make sure that we're not overwhelming one particular ward. Same with falls, you know, it's the same with falls. We can very easily now recognise a ward that has had a high number of falls or patients, you know, so it helps falls reductions. And the other one is tracheostomies and neck breathers. It was quite a problem for us. We never knew where they were. People would talk about acuity of patients, and we never knew where our sickest patients was, where they were. But now at a touch of a button, we've got all that visibility of where our patients are, and we can then make sure that our ED patients are placed in the right place the first time, because we know that's better outcomes for patients. So no, I'm saying next slide. I've got to do it myself, haven't I, everyone? Next slide. Okay, I'm not going to. This is self-evident. Obviously, with improved flow, we have an improved emergency department performance. We continue to be in the top 10. I'd like to say the top 10 performing trusts in the country. We very rarely have 60-minute handovers. Probably maybe 1 or 2 a week, if that. And the interesting thing is this Opal 4. So we very rarely declare Opal level 4. And if we do declare Opal level 4, it's probably on a Monday after a tricky weekend, but we recover very quickly. So if you look at us as a system, we are outliers in terms of very rarely declaring that we are in Opal level 4. And of course, we know the longer patients are in ED, the higher the mortality rate is. So, you know, we're really proud of the work we're doing to get our patients out of the department quicker. And in line with that, our continued good improvements in terms of ED. Oh, the next slide I've got to do myself. Okay, so I think I don't think. I mean, Carl talked about releasing time. I can't put my hand on my heart and say these improvements that I'm going to talk about now are based on an electronic bed system, but it is about releasing time for managers are no longer running around chasing beds, which gives them headspace to do the improvement work, which obviously is going to lead to these improvements. So you'll see there. We've got no long waiting patients in MTW and haven't had for about 18 months now. That's allowed us then to look at patients waiting at 40 weeks. And again, we've got about 600 patients waiting at 40 weeks. Theatre utilisation, normally about 86%. And our DMO1 position is 97%. And as I said, you can't correlate that particularly with the bed management system, but you can with the time that it's released to give people headspace to do the improvement work needed to deliver those improvements. It's the same for cancer. We've consistently delivered the 62-day referral to first treatment, always above 85, with a backdrop of increased referrals. And since the 28-day, the new target for faster diagnosis has been introduced. We are consistently meeting the 75% standard, and are working hard to make further improvements with that. Next slide. I don't know if mine or yours, Carl. Over to you. I'll chip in.
Thank you. So yeah, just to run through, because I think what we're trying to say is that the technology is never just a single point panacea for every problem, but what we commit to as part of the approach from TeleTracking is that we recognise the importance of understanding on the ground the work that is being done and the challenges that everybody faces, which is why the team fundamentally is driven by former clinicians or senior leaders within NHS. Everybody has experience within working within the NHS and helping understand the challenge that we've got. And so what we try and do is say that this isn't about just a technical rollout of a solution. This is about how we continue to engage in partnership along the life of that contract to continue to drive benefit from the system. And what we do at MTW and what works really well is we have consistent conversations around the strategic ambitions for the year. How does TeleTracking support and enable those ambitions? And then our optimization team kind of work in partnership with them around how we might maximize the benefit and support those kind of strategic ambitions. And we've got some really good objectives for the next year to really push on and drive major benefit from this system. So I suppose the first lesson that we kind of put in there is don't underestimate the technical rollout and the importance of the cultural change. We talk an awful lot about people, process and technology, but quite often technology is dropped in and then it's kind of seen as it either works or it doesn't. And that really isn't the case. We've got to commit both parties to continue to do that, and we certainly make that commitment. Better understanding of user profiles and roles. What we're in the process of doing right now is making sure that we understand each user profile across the whole of the system. How do all of those individual workflows need to work for the client? How do we support them with easy ways to manage and drive benefit from the system? So what we're trying to do is make sure that we drive benefit from that and we better understand the profiles, make sure that we understand who the biggest users are, where is the biggest impact, because I think Sally would say that we were most surprised. Perhaps we thought a certain user might be the biggest user of the technology, but we found benefits elsewhere and efficiency came from those areas in this first phase. And then, as with any system, there's a lot of energy to start with. People are committed to actually driving benefit, and then that starts to fall off. What, again, MTW, to their credit, have done really well is go back to the drawing board and say, right, where have we understood that there may be workarounds? People have dropped off with the process. And first and foremost, why is that? Not necessarily just to drive it. If it's not working for people, let's understand why it's not working for people. Let's think about how, as partners, we can kind of adapt and change things, make that easier. And so that consistent re-look to it as a continuous process of improvement, and the technology as an enabler of that becomes really, really important. So, I mean, our key message fundamentally is that we commit to this as a partnership whenever we do this. We don't see this as a technological solution. The reason we come from NHS backgrounds is because we care about driving the outcomes and the benefits for patients. So I'll leave it there. Sally, have you got anything to add?
I'm just going to say, yeah, well, no, I'll just give you an example of how we've worked together. I think I won't go into it in detail, but we introduced some new roles. So the wards gave up a clinical support worker, and we introduced a flow coordinators whose sole responsibility in reality, or one of their main roles, was to update the teletracking system lifetime. So we thought that was a good idea. We had a recruitment issue. We had a lot of nurse vacancies, and thought that was the right way to go. We have learned subsequently. We've looked at, actually that's great until 4 o'clock, but at 4 o'clock those people go home. And we have got a problem then with our teletracking performance after 4 o'clock. So that's what Carl means around, we think we have a solution. We review that solution and work collaboratively to see how we can make things better. It's we did circumnavigate the system. These badges that the patients, or the badges, the badges, they're called badges, but they're like an eye watch that patients wear, have to be dropped into a drop box to get the efficiencies. That automates the portering, bed turnaround teams, etc., etc. And to be really honest, they're a bit clunky. Carl, don't tell, they're a bit clunky, and patients with dementia or patients with challenging behaviour would pull at them, pick them off, and we'd lose them. So we kind of circumnavigated the system and said, okay, for some patients, we'll still get the benefits of using the drop box, but we'll put the badge on the patient's door or on the patient's locker or wherever that might be. So initially we thought, great, we've got a solution to that, but actually one of the next steps for us with our partnership will be tracking patients through endoscopy, the cath lab and the theatres. And that won't work. The patients need to have the badges on. So again, we've had to work collaboratively, go back to the drawing board and think, actually, how can we work together and come up with a solution that means the badges are easier to navigate or easier for patients to wear. So I think I would echo what Carl has said. I mean, our relationship has almost started off as a business relationship and ended up almost as a friendship relationship. We are talking all the time. So yeah, that's probably it for me, Carl. Thank you.
Yeah, no, great. I think it's a really good example, and I think what we try to do there, Sally, was obviously think about how we can help tackle that problem. We're looking at different size badges. What can we do about kind of rules-based systems that might make things easier? There's work to be done with that. That isn't easy, and so we, like I say, we don't just kind of lead you to it, but we. I agree in terms of the friendship. It's been a really good working partnership, and there's lots to come hopefully this next year. Thank you. I think that is next slide. That's just a picture of the Care Coordination Centre in Maidstone.
That's the Care Coordination Centre. It's probably a little bit different now. What we've tried to do, just so everyone's, what we've tried to do is the Care Coordination Centre initially was just about flow, but now we've got a quality dashboard in there, acuity dashboard, so we can actually incorporate quality with all of the operational flow conversations that we need to have. Yeah, it's probably a bit different now. Questions?
Right.
Any questions?
Thank you so much, Sally and Carl. I just wanted to say that office space looks amazing. I've noticed the sort of the foot tracker thing, the sort of peddler standing desk. Everyone's got a massive amount of visibility. I mean, it looks ideal for what you're trying to achieve, just to keep people on it and moving those patients through. So I'll open the floor to questions. So either pop them in the chat or raise your hands. I've got a couple myself to kick us off. If I just pause there to see if any hands come up. Okay, I will kick us off. So you've mentioned, I'm so really impressed, I suppose, just to say, with your sort of 5% performance, it must be really nice for staff to come and work in a place where the performance is counter to what we know the national kind of narrative is always. And I think that must have a big impact on staff resilience and, general wanting to be at work and be happy at work. I guess I'm just wondering, you've mentioned some of the unintended consequences around being able to free up operational managers to do some of the other improvement work. And I imagine that was unintended unless that was something that was sort of explicitly thought about in the beginning. But I was wondering, what other sort of strands are you starting to tease out? Is there anything exciting in the pipeline that you might want to share that I guess has been enabled by the fact that staff can focus a bit more on rather than that burning building, on the more what's going on behind the scenes?
Yeah, so do you want to talk about that?
Yeah, no, that's fine. So I think we are particularly so what happens is, so one of the downsides of TeleTracking or not TeleTracking, or a bed management system, is that there's a loss of social interaction a little bit. So one patient goes, you drop your badge, it frees the bed up, the bed's cleaned very quickly, in comes your next patient. And when you speak to some of the nurses, it has released time for them in terms of the phone calls and all those kind of things, but it hasn't helped. If you talk to them and they talk about cultural change, they don't have time sometimes now to talk about, were you drunk last night? Have you got a new boyfriend? Whatever the kind of social interactions were in between patients. So our next steps, we haven't done it yet. Carl and I were talking about this recently, is how we can perhaps support the wards with all of our improvements to almost have a 30-minute social huddle or something. Because I think we recognise that with technology, you do lose a little bit of social interaction. So in terms of that, I think we are looking to try and think about how nurses and other users can socialise in between patients, probably. Carl, anything else that we've...
Well, I think, I mean, yeah, there's one piece on that kind of MDT work and enjoy at work, and making sure that we create the space for engagement and interaction. That's definitely one piece. Then you've got the work around the discharge processes, that we're looking fundamentally about how we understand those pathways and support those pieces of work. There is the individual user profile work, which we're working on. And there is the potential outpatient need. How do we kind of create use from an outpatient perspective? So we're right at the kind of precipice now of, we've done that first bit that's created the space. Now what can we do that's really exciting? How do we support discharge process with something really exciting? So as an idea, things like delivery of TTOs into the community so that you don't wait before discharge. We're exploring opportunities around that, and then working with other partners around that, how we might enable that. But we're very much in the infancy, aren't we, Sally? It's kind of setting up the strategic boards, getting the right governance structure in place, and once we've got that, we can then start to think about the really exciting piece of work, which really is an exploration for all partners. You know, this is the kind of acceptation, is how do we use what we know to drive benefit in one area for other benefits that we might not really understand, and do that as a partnership and explore it together. So we're starting off on that journey, and I think in 12 months time, it'd be really interesting to reflect on what we've achieved at MTW again as the second cycle of work.
Thank you. That's really, really interesting to hear about. I'll just check if anyone's got any questions to ask. Raise your hands or pop them in the chat. Please. I don't imagine any question is too sort of small. It'd be really interesting to hear what your thoughts are, or even if you just want to just find out a bit more about one of the slides that's already been discussed. So I work in community services, and I'm just wondering what the engagement with community teams has been for safe discharges out. And I'm just wondering if you could talk us through a little bit about that. Often that's where the interface of that handover and the trust of trusted assessor roles and any other of that risk management in the community.
So we're not an integrated trust. So our community hospitals are managed separately. We have deployed, or TeleTracking have deployed the system so in the community. So we have got visibility of the community beds. So that has been helpful. I think and we're at the beginning of, like everyone else is, introducing a transfer of care hub that we haven't quite got a head around yet. So I think that we are now much more sighted on community provision. Have we nailed the trusted assessor model? Probably not. I would like to speak to anybody who has got that model. So although we've got visibility of the beds, we still have that to in and fro in. You know, our physio says one thing, the community physio has a different idea. So we haven't actually cracked that. However, we do have on site our community partners, social services, and the voluntary sector. So we do integrate in terms of our conversations, but in terms of I would say it's not a slick process at the moment to get our patients out onto a pathway to bed, despite having visibility of those beds. I wish we could.
I think there's two parts to it, really, isn't there, as well? There's the opportunity to have genuine interaction around a single point of truth, and you've both got clear pictures, and then the time it takes to build trust and start to develop the work that comes off the back of that. I think what we've done in the first instance is create the opportunity for the interaction, make sure that we've got a clear sight of the right picture, so that there's no kind of bounded rationality. Both parties aren't arguing over what is true and what isn't. And what you see locally is a really good relationship between those partners. I mean, we have very little interaction with you guys, but from what we do, we see really good interaction between the two of you, and a really genuine commitment to improving that part of the process. And so I think it's going to be really beneficial. We've started the process there, as we have in some of the sites, but it's a new development as we broaden that out to kind of what we call boundaryless, beyond the four walls of the acute into the community support and ICS vision, essentially.
I think what is positive is that we are now that kind of partnership is spreading out to our community organisations. We are doing a collaborative piece of work, aren't we, Carl, to kind of unpick all of those pathway delays, which we wouldn't have been able to do previously, I don't think. So we were on a journey with our discharge pathway improvements, I would say.
Thank you. That's really, really useful to hear. And I'm glad you haven't cracked it, because I certainly don't know anywhere that's cracked the trusted assessor model. Actually, Lindsay, would you mind if we stop the screen sharing, and then I'll bring Jenny in, please, and just look out in the chat as well for any questions. Thank you. Jenny.
Thank you, and thank you for your presentation. Yeah, I've worked in one place that's had an electronic sort of bedboard system and one place that hasn't, and it's very different, isn't it? I was just going to ask about data quality. Obviously, what you are seeing in your screens in your control centre is only as good as the data quality that people are inputting at ward end, ED end. And I know that you sort of said about your flow navigators going at 4. So is it the nursing staff that input that data? And how do you, I suppose, get assurance that everyone is putting that in a high quality way so that the decisions you're making in the control centre are accurate, if that makes sense?
No, it does. And you're absolutely right. The majority of that information is inputted by nursing staff, whether that be ED or in the ward areas. And we have struggled at times. We've struggled at times to assure ourselves that the data that's being entered is correct. There's no point pretending that from day one that data was correct. What we've had to do is kind of it sounds really archaic, but we have got groups of an integrated discharge team, as an example. They keep a manual record still of their number of patients on each pathway, where the nurses are inputting it into TeleTracking, and we've had to do a correlation. We've had to actually kind of cross-reference for probably weeks at a time to make sure we were all comfortable with the information that was being inputted by the nursing team was correct. We've also struggled with, I think, and we're probably okay now, about how we hold people and divisions to account for their data entry and their compliance with the TeleTracking requirements. So we have got nursing dashboards, divisional dashboards, lots of dashboards, where we're having user group meetings, holding people to account and cross-referencing the data that nurses and other allied health professionals are putting in. But I think it's been a labour of love. We have collected the data manually and cross-referenced it, and we think we're at a point now where everyone's agreeing that TeleTracking is the one version of the truth. But it's been a long journey, and people.
It's a real shift, isn't it?
It has been a long journey, and I think Carl talked about cultural change. You know, this is a different way of working for nurses, and you have to sell it to them as having a quality input. Otherwise, they're just not interested. So it's been a 3-year journey for us, and I think we're at the point where we believe our data to be correct. Carl, would you agree?
I mean, I know
absolutely.
Also, I think there's a bit of pushback, isn't there, that I've heard before when I've been in organisations that's used it, that we're asking the nursing staff to input this data, and actually, like you just said, they have less downtime in between. Like literally, that bed doesn't get cold, does it? So they are constantly running at 28 patients to ward. It was difficult. Did you have to adjust staffing at all for that?
No, we didn't adjust staffing. I think, as I said previously, the wards gave up a band 3 clinical support worker to do the functionality of the flow coordinators. I think that we didn't go into details on lessons learned, but a lesson learned for me was that particularly for nursing staff, we introduced electronic bed management as an efficiency program of work. And you're absolutely right, Jenny. For nurses, talk about efficiencies. It doesn't mean much. It doesn't mean much to a nurse. We care about, is that patient going to get fed today? Is that patient going to have, whatever? So we had to kind of really change tack. And we have now these flow engagement days where we are now talking to nurses about, as I said to you previously, the quality elements we didn't talk about initially with the rollout, but now we're able to quantify quality outcomes for patients. it's easier to get that engagement from nurses. But a lesson learned for me, I say it to everybody, was don't talk about efficiencies to nurses, talk about quality. And that's what we've had to do. We've had to kind of focus our conversations.
Yeah, and I will just add, so I think what we see as a distinguishing feature is we are capturing novel data with TeleTracking. It's one of the kind of benefits of that. This isn't data that we're pulling and scraping from elsewhere in the system, so that we don't have a true representation of whether that's accurate data. Secondly, we then try and make sure that if we can automate it, so it doesn't require human input to kind of, we do that, we automate that kind of flow of data. Thirdly, you take the workflows and you make sure that these align to your current workflows so that you can kind of, or improve your current workflows, and then you can limit additional exposure to the kind of interaction with the system. So you can actually say, well, this becomes a fundamental part of the way we work, and it's beneficial for all parties to capture this data. So example will be your board round. If you're kind of updating in a really simple way, light touch, minimal kind of input way, but all of that data is captured at ward base and then fed to the system, or cumulatively across the hospital in real time, those updates that take place, you're getting a constant flow of real-time information without a constant need for somebody to kind of stay on top of the input because it's embedded within the practices.
I guess great question, Jenny. It's really, we've dove really deep into some of those sort of strands. We've got a couple of questions in the chat, and then I'm aware that we're sort of running out of time. So if anyone's desperate to put a question in the chat, then please do, and maybe we can do a little bit of a follow-up if needed. If people want to reach out to you, Sally, and as you said, you've offered visits, so if that's open. So Ingrid's
we're like experts. We're like experts with visits.
Ingrid's question is around. When you started tracking patients, did you notice any trends? So was there some analysis of the data that you were starting to get that might indicate what was happening? So why was length of stay higher? And so how did you address that? What was it that you addressed? And then also, I guess she's just wondering, is it just an efficiency? You've just made it more efficient. So was there any sort of data that you were able to get some insights into why was length of stay higher pre-intervention, as it were, than post?
I don't think we have got that data clearly. I think that if you was the first part of the question about tracking patients, I didn't hear the first part of the question. What was the?
So when you were able to start tracking patients, did you notice any trends?
Sorry. Oh, tracking. Yeah. I was going to say I can talk about tracheostomy patients all day long.
I'm getting over a cold, so I'm probably a bit nasal, so apologies. So did you notice any trends when you started tracking the patients that meant that you understood why length of stay was higher, or was it just an efficiency savings that basically led to the improvement? Well,
I think there was obviously an efficiency saving, but I think that we all know that getting the right patient in the right place first time will support a length of stay reduction. And I don't think we always did that. I think it was quite easy for us with a pen and paper to say empty bed, patient A into that bed. I think now we've got that qualitative data around us that we're able to put patients in the right place first time much more successfully than we ever were, which in itself is probably one of the reasons why we have reduced our length of stay. As I said, a medical outlier in surgery, add 3 days to their length of stay. Don't have an outlier in surgery, that patient's going to go home on a Monday rather than a Thursday. So I think it's all about getting the right patient in the right place first time for me. Would you agree, Carl? I'm just thinking.
Yeah, absolutely. It's a great point. And I think that the first phase very much was there. What were the kind of quick wins that we could deliver? Where was the key insights that we'd already kind of had an awareness of? The second phase of the work is exactly what you've mentioned in that, which is let's get smarter and delve deeper into the data, really understand it, and how can we derive insights from it? We can make some major changes to the way we work. So the package contains a full analytics suite, so you have all of the kind of core data capture, and that will feed into an analytics suite, and you can manipulate that. And MTW, like some of our other partners, create their own dashboards, and so that they can drive insights in the way that they want to, and focus on specific areas, and we enable that. So that will be the next piece of work as well.
Right, maybe you can come back and tell us about that once you've done that, maybe next year.
Absolutely.
Just a final question from Lindsay, who's asking around cultural change, and she's interested around the rollout of technology and how did you make it happen? Because that can often be a bit of a sticking point with new tech and then getting staff on board with that.
Like I'm taking all the questions now. Okay, so I think that we've probably covered a lot of that question. I think that the technical rollout was quite easy. I think it was 20. I wasn't part of the technical rollout. I think it was a 20-week rollout session. So that was quite easy. But as we've spoke about before, getting the users to actually understand the benefits was more difficult. We rolled it out in COVID, which wasn't great because we couldn't have kind of user group sessions. It all had to be on Teams. So we missed a bit of social interaction there. But I think we have gone back. I think Carl spoke about it earlier, to understand each user group and what that user group needs to deliver to deliver the efficiency. And I think we just kind of, as an organisation, thought, okay, we're going to roll it out to everybody. Everyone needs the same training. Everybody needs the same input. Everyone needs, and it was quite generic. So I think what we've done is had to sit and look at that and understand the user group profile and go and meet with user groups and talk to them and engage with them in a way that makes it real to them rather than just rolling out a technical system, is what I would say. It's user group profiles. We didn't understand our user group profiles. We assumed that train a nurse, train a pharmacist, train a physio, and we could do it like that, but that's not the case. You need to understand the individual users.
Yeah. Okay, I can't see any more questions in the chat. We've got a couple more minutes if anyone is wanting to know more. But I just wanted to say thank you so much, Sally and Carl. It's been really interesting hearing about how you've managed to sort of do that transformation work. I guess, I'm curious to see how many people just reach out and, it almost feels like, well, why would you not do this if it's working so well? So there's something around in our sort of curious mindset around being open to learning, around thinking, what can we take away from this to be able to sort of drive some of the similar improvements that you have. And you've had a 3-year journey, so clearly you've done a lot of work around this. So yeah, essentially, just wanted to say thank you very much. As I said earlier, we'd really welcome others if you want to share what you've been doing locally and helping us all improve how we deliver for our patients and our staff. Then please scan the QR code, get in touch, let us know, what you'd like to talk about. And in the past, in sharing elective stuff, I know that some trusts did get together and they delivered sessions jointly because there were some similarities between the work they were delivering. So if that's you and you want to do that, then please put yourself forward. We can't have the content without you. But thank you very much. Appreciate your time, and you've got a few minutes back in the diary to maybe have a little comfort break and get ready for your next session. I'm sure many of us have to go to, but appreciate it.
Right.
Take care
Thanks
then.
all.
Bye bye.
Thanks, Sally. Thanks, Rebecca. Thanks, Lindsay.
Bye.